Well, welcome everybody to ASA's Reproductive Health Education Panel. I'm Lauren Teller. I'm the chair of our co-curriculum committee who worked to organize this event. I'll give a little bit of a brief purpose of this event. Oh wow, and then I will introduce our panelists who are so awesome that they decided to come and share their expertise and everything. So ASA has been working on a reproductive health initiative, which includes funding for Plan B as well as condoms made available to students. So in conjunction with the Dean of Students Office, we now have 6 dispensers on campus, 2 of which will be available for students to get access to Plan B, individually packaged pills, not doses. We'll talk a little bit about that later. One will be coming out soon in the campus covered area, and then one will be made available in the campus clinic. Our other 4 dispensers will be used for condoms. We have 3,000 condoms in stock currently. And so those 4 dispensers will be in Bergsacher, Grand Scout Staubig, and I think Wagner. So that's kind of a little bit about that. I will now introduce these panelists. So if you could just share with us your name, pronouns, area of expertise, including if you're a member of staff or faculty on campus, just kind of what brings you here today, anything you want to share. So hand this over to you, and we have 2 microphones, so maybe I'll hand this to my right, and then we can kind of just go down the line.
Thank you so much for having me. And thank you again, I mentioned this to you before we started, but thank you for doing this work. You're all students putting this together, already have yourself extended in multiple different directions, doing labor in our classrooms. So thank you for putting this together. I think it's necessary to put into context alongside having the actual physical resources. So hello, I'm Dr. Spencier Ciaralli. I'm in our sociology department here at Augustana University. I have a focus within medical sociology. So I teach right now, actually this semester, I'm teaching medical sociology. I also teach a race and gender in medicine and healthcare. And some of my research is this intersection between social identities like race, class, gender experiences as they pertain to the experiences within our healthcare systems and institutions. Did I say my pronouns? She, they.
Hello, my name is Sarah. I'm a proud graduate of Augustana College. Woo. Things have changed since I've been here. This used to be the bowling alley. It was a great bowling alley. I have been a nurse for 38 years, and I primarily have done public health nursing, and I would say 75% of my nursing career has been in family planning and STDs. If you have questions about bits and parts and how we prevent pregnancy, I know that answer more than likely. And I hope to have some good information to share with you. I do need to say that I work for Sanford. I love working for Sanford, but what I say is not the opinion of Sanford. It is my opinion, and it's based on my work experiences, and I'll try to keep my political thoughts to myself, and I go by she and her.
Hi, I'm Madison Peterson. I'm Madison Peterson. I'm the Associate Athletic Director for Compliance and Senior Women Administrator for our athletic department here. I think a big part of me being a part of this campus is my Senior Women Administrative title. That piece of my job is making sure that not only our females, but all student athletes are taken care of and have the resources and everything that they might need, and I go by she and her.
Michael Mullin in the history department. I have absolutely no expertise in much of this, but I am a father of a single daughter, and so some of the issues that you're confronting today are issues that I deal with as a parent. I go by he and him, and I will chime in when I can, but I'm not a medical specialist in any sense of the word.
Well, thank you guys for sharing. I just want to preface and say, hopefully this isn't too loud. That by no means do you have to answer all of these questions. If you have certain questions really provoke thoughts that you may have, feel free to answer those, but you can also refrain from commenting. So our first question is, what is the history behind Plan B/contraceptives, and how can students be aware that they are appropriately using the medication? Anybody want to start with that one? Okay.
All right, so I really like this question, and so I wrote out a piece because I wanted to make sure that I didn't miss anything, and then thereafter be like, I really wish I addressed this, because I think this is a very multifaceted conversation we need to be having. So first and foremost, Plan B prevents ovulation if it has not already happened, and does not prevent implantation of a fertilized egg or interact with an already established pregnancy. So some folk have understood emergency contraceptives as a form of abortion, and so I just want to put that out there. Abortions are healthcare and are necessary, but that is not what emergency contraceptives are. And so again, research shows that a morning after pill, which is oftentimes what we will call it, does not prevent implantation of an already fertilized egg. So it's preventing ovulation if it has not yet happened. So think of Plan B, and correct me if I'm wrong, over here with our expert, is perhaps a strong dose of a birth control pill.
It's a strong dose of progestin, which is half of a typical. It's a strong dose of progestin, which is half of a combined birth control pill, which are typically estrogen and progestin. It's a normal hormone for women.
Thank you. And so taking a morning after pill, as they are often called, has a 75 to 89% success rate if it's taken within 3 days after having unprotected sex. Now, when I say 75 to 89%, what that means is that the pill works 75 to 89 out of 100 times that the pill is taken within 3 days. And so you can take up to 5 days after unprotected sex, but the longer you wait to take it, the less effective it is. And keep in mind that when I say sex in this situation, I'm also defining it in a very heteronormative understanding. And sex looks in a lot of different ways. And sex is not just a penile-vaginal interaction, right? But in this case, when we're talking about reproduction, that is how I'm referring to it. But I also just don't want us to assume that's the only way we can understand and talk about sex. And so I also want to note that the difference between Plan B and other more generic forms of emergency contraceptives, say My Choice or My Way, those are things that I carry in my office for students if they need them. They all have exactly the same effectiveness, no matter the difference in that cost. So I know we will have, again, accessible emergency contraceptives on campus, but if you are, for whatever reason, not on campus and you need to access the morning after pill or emergency contraceptive immediately, I do want to note that My Way runs for around $6 to $8 online or at local stores. Yes, I bought it online a couple weeks ago.
Online doesn't help you a whole lot if you've had sex this morning.
Absolutely, but you can also go to Costco, also has it. We'll have it for $6 to $8. But I think it's important to note something that's often missing on these boxes is that the pill is less effective if you weigh more than 165 pounds. So this results in many problems, right? Such as folk taking the pill thinking they're getting the exact same results as any other consumer, but can actually result in pregnancy. And of course, the underlying fat phobia that's really at play in the pharmaceutical industry in not accounting for a majority of people. So in this case, some will recommend taking the pill Ella, which is most effective for those who weigh between 155 to 195. But again, this doesn't address the needs of folk for over 200 pounds, right? But again, it's still better than the standard emergency contraceptives. And so I just think that's something really important to have a conversation around when we're talking about, do we know what we're taking? Do we know the effectiveness? And so on. You know what, I'm gonna go ahead and pass the mic, so I don't take up too much time.
I can talk for hours, so stop me. I think the awareness and the activity that you're doing here is very, very important. I think one of the leading causes of unintended pregnancy is knowledge. If you don't know what things are happening and when pregnancy can occur and what you can do to prevent it, there's a greater chance of an unintended pregnancy. But what I want to make clear is it is called emergency contraception. It is called Plan B. It's not Plan A. In some cases, if you take it late, well, it may not work at all if you've already ovulated. It stops ovulation. It may thicken mucus so sperm can't get all the way to the target. So we might be talking 75% effective, 80% effective. When there's birth control methods that are 99.9% effective, that will carry you through for 3 to 5 years, and it's 6 blocks from campus. It's confidential, you don't have to use your insurance, and most students don't make enough money, it will be no charge. Free birth control is already here, and we're happy to see you, and we have a lot of fun at clinic. I think condoms are something that are very important to talk about, not just for pregnancy prevention. Perfect use with a condom, you're at, 98% effective. That's effective birth control. Typical use, human use, 85% effective. Because you're outside in the car and the condoms are somewhere else in the dorm. You have to have them with you. Anytime we have to stop what we're doing to use a birth control method, the failure goes up. Anytime a person has to make a decision to use birth control, the failure goes up. So birth control pills are less effective than a patch because it's a decision a day versus a decision a week, versus a vaginal ring, which is a decision a month, versus Nexplanon, the implant in your arm that you can't mess it up. You really can't. But condoms, we also have to talk about the STD problem crisis in our community, in our state, in this campus, in USF. Syphilis is up 5,000% in our state this year, and it's only October. And syphilis will kill you, and it harms babies. So there's a whole vast of other things that need to be talked about. Yes, prevention, and yes, have it available because it's an emergency, but it shouldn't be Plan A.
Who wants it next?
Well, you took my thunder.
Sorry.
No, the role of condoms is really important, and not just for the prevention of pregnancy. When I was an undergraduate, HIV had just hit the scenes. And we don't talk about HIV, we don't talk about STDs often enough anymore. And so there's more benefit for condoms than just the prevention of pregnancy. And that was the point you were making.
Yeah.
But I think we forget some of these other diseases that we might encounter. And so I was going to talk about condoms not just as prevention, but preventing other illnesses that at one time, when I was, say, an undergraduate, had the potential of killing us.
Right, back to that. And then it's back to you, so think of something.
I already got something.
When I was a senior nursing major taking public health, HIV was this fascinating hour-long discussion about this public health issue in San Francisco. And look where we are today. I have a patient who is HIV positive and is taking a medication, and she's absolutely zero. We didn't have that. And then we have PrEP. And if you're going to talk about Plan B, you need to talk about having PrEP, because that is 98% effective in preventing the transmission of PrEP for anyone. That's critical medical information that a lot of people I speak with don't know about. Syphilis up that high, if a woman is pregnant and has syphilis and is not early diagnosed, that baby has a 25% chance of dying and a greater chance of having serious birth defects. We have to do something about this. And one of the things that the state in Sanford and Nevada are doing is when a woman is pregnant, she gets screened for syphilis at 12, 28 weeks, and at delivery. What about the woman with the healthcare disparity that does not get into prenatal care until she's 34 weeks pregnant? That's too late. So there's a whole vast amount of issues that condoms can slow that tide. So also very important.
Thank you. while we're talking about condoms, I would also like to note that there are things called dental dams because, believe it or not, pleasure, and things other than sex and preventing STDs and HIV can also be, because a lot of times we're also then talking about ways to have oral stimulation using condoms, right? But also dental dams. We can also talk about ways we can have safe sexual interactions that involve the use of protection with, a vulva and a clitoris and and a mouth. But I don't think we have those discussions around dental dams quite as much and nearly as much as we do around condoms. So, I also want to talk about possible side effects that you might experience after taking an emergency contraceptive. So what is perhaps normal or abnormal in that experience. It's common to have a change in your period because again, it's going to influence a lot of folks' different period patterns. So a period may come sooner, it may come later, heavier or lighter bleeding or spotting can be expected. Tender breasts, cramping, or nausea or headaches are also possible. So things to just note that could be, potential side effects. And then the beginning of this question was asking about the history. so I'll quickly say that Plan B wasn't accessible over the counter until 2006. And Plan B wasn't, accessible without having a visit and a prescription from your doctor, which effectively barred many folk from having access to Plan B altogether, again, until 2006. And even then, it was only for people who were 18 or older. And so it wasn't actually until June 20th in 2013 that the FDA actually approves Plan B for the over-the-counter sales with no age restrictions. And I think it's really important to hear the context in which emergency contraceptives have been made accessible, to really reckon with this shocking recency of this fight for reproductive justice, particularly in light of recent events.
So, okay.
Yes, it works.
This has nothing to do with what you just said. Your eyes lit up when she said 2006. Like, oh my God. You could be arrested for homosexuality as late as 1976. So the reason I bring this up is one of the things I've learned in teaching certain classes is this history isn't as far back as you think. And so the world was fundamentally different 50 years ago. And so some of the things you take for granted, and I think this is what some of the conversations about right
here on the stage
is we've seen how much things have changed, we would say, for the better. And one of the things that seems to have happened is that women have fewer choices as a result of a court case. And so when I think about civil rights, when I teach my history, it's not always advancing. Civil rights and freedoms are not always advancing. It's oftentimes 2 steps forward and 1 step back. And this is an example of that. And so when your eyes lit up with 2006, you probably don't know that you can be arrested. It was illegal to have interracial marriage until 1966. Your parents were probably alive then.
I was alive then.
But you're, sorry, we're both old enough to be their
I
parents.
remember that. Grandparents? No.
I didn't mean to interrupt and sidetrack it, but I think in a lot of these conversations, that history part is missing. How recent was this? How far have we come or not come?
All right, I can't help myself. I can't help myself. You want to chime in on any of that? Because I have seen things happen in my lifetime, in my career, using medication, a pill, to end a pregnancy. And I can tell you right now, I am not a cheerleader for abortion. I'm a cheerleader for women not having to be in that position. And I'm a cheerleader for women being in absolute control over anything that happens to their person. And I was going somewhere with that. Oh, how do we, I was. How do we want to make that different? How do we want to not take 5 steps backward? Well, you register to vote. And that's where change comes. People get angry and people get on an issue, and I would never tell anybody how to vote. But if you want things to be different, that's what you do.
Answer more or less questions.
What was the last
But not all folk who can have the ability to get pregnant are women. So I just want to note that there are a lot of non-binary, agender, genderqueer, and trans men who can also be in this conversation and are important to include in that. That's all.
Yeah. Thank you guys. There were a lot of like topics that are probably going to cover our later questions brought up during that, but that was not a discouragement from just taking these questions and answering them as you please. So for our, for our next question, I think we're going to go with addressing some of those healthcare disparities. So how does a person's different identities, how do different identities affect their rights and access to reproductive services? Who would like to start with that question? Awesome.
I think in this day and age, anybody should have access to what they need to be safe and what they need to be the person that they are. It doesn't matter what you consider yourself, but I just think making sure that even on campuses, this is the perfect time for you to figure out who you are as a person, and a campus is a great area to kind of show where the next step or what you might need, and having those resources available are super important. But also knowing like this is the time to have a judge-free zone, and also give people the opportunity to explore and to make sure they're making the right choices before they head off into the real world and, you know, make those next steps. And that's a huge part to everything in life, not just this topic, but it's a good time for you all as college students to figure things out and make sure you're taking those steps forward into the real world.
I have thoughts. We know that there are health disparities in the LGBTQ community. We know there is a feeling of a lack of safety, and when I say we, I say health professionals. Personally, I know there's reasons for people to feel less safe when they seek care, and the provider they chose is not somebody that will be understanding, empathetic, and caring. And I was on a committee at Sanford, and we were making great strides. And going forward, we had input from the community, and we were making these plans, and COVID hit. And I can tell you, COVID changed everything. And extra things we like to do at Sanford kind of got obviously put on a back burner. But the studies are clear that it's a serious issue. And it's something I think most healthcare facilities are working to improve. Do I have great answers? No. But I do keep a list of doctors in my office that I know are empathetic and will prescribe, and that. So that was my thought. You chime in.
So I want to talk about a different type of disparity, and that's between the urban environment and rural South Dakota. I've done a fair amount of research on rural South Dakota medicine for a project. Imagine only having one pharmacy for your county or your city, and knowing that you have to go there, knowing that that pharmacist is going to your church. That is one of the questions with rural healthcare, is the limited opportunities that women, in particular in this case, have. I've heard way too many stories about women going to the CVS on the corner there of Minnesota and not being given their birth control because the pharmacist was convinced they were being promiscuous as opposed to treating them for cysts. It's even worse in rural South Dakota. And so one of the areas that has not been discussed yet when it comes to healthcare disparities is that urban-rural divide, which really is going to impact an awful lot of our students and impact an awful lot of women in South Dakota.
Absolutely.
Thank you. And so kind of in light of my response to the last question of this importance of historical context, I think, again, historical context is important to frame our current actions in light of reproductive justice. So when we talk about reproductive justice, this means it's not just about a conversation around emergency contraceptives and abortion care access, although those are certainly important. But it's also justice and access to parenthood in a safe and equitable manner. And I say that because American history is really rife with forced sterilization of many low-income women and women of color. The birth control pill was pushed into poor Black communities to control the reproduction of people of color. Planned Parenthood has a very troubling racist history around this in particular, and that's something important to know. And all this to say, we just need to maintain an intersectional lens when we are talking about reproductive justice, to recognize that justice might look different for different people, and to really just ensure that we don't whitewash this movement. All of that, I just wanted to provide that context. Taking that to mind, and in terms of current access though, we do need to focus on low SES, so low socioeconomic status communities and families. Because when we do talk about things, when we do talk about things like abortion care bans, what we're really talking about is lack of access for poor and working class individuals. Someone from a middle class or upper class background can just travel to a different state to get their abortion. Someone from an upper SES status can walk into a clinic and have access to birth control, an IUD, can walk into a store and not think twice about the cost of condoms or emergency contraception. So for someone who is low SES to even attempt to get access to things like emergency contraceptive, or in particular, let's use the case of abortion, they have to consider a multitude of things, right? Think of one, do they have a mode of transportation to get out of the state into a clinic? Two, can they afford to schedule around or take off time off work? Three, can they afford childcare while they are gone? Because oftentimes people seeking abortions are already parents. Four, majority of states require a 24-hour waiting period between first visit and actual procedure. And so now that requires one to factor in if they can afford a motel or a hotel or somewhere to stay. Five, can they even afford the abortion procedure itself? The list goes on, you're getting my point. And so when we're talking about barriers to reproductive justice, we need to think of the structural barriers in place and what those may look like for folk of varying experiences. Because my barriers of access will not look the same as someone else's. Kind of like when we're talking about emergency contraception and the ridiculous weight limits, right? So justice and access aren't fully realized if they only apply to a certain group of people.
Okay, those comments on reproductive justice provide a really, really nice transition into our next question, so thank you. What is something that students need to know or hear during this time of political tension regarding reproductive rights? Sarah, would you like to go first?
You are not helpless. There are ways that are not expensive to keep yourself safe, to keep your friends safe, to keep your partner safe. What do you need to hear? There's light in the head in the tunnel? I don't know. I can tell you the last 4 months, 3 months, it's been difficult to hear women's stories, to hear that I don't have a choice in this pregnancy. I have subsidized housing. I can't have another physical person living. We can't have another body in this apartment. If I have a child, I'll lose my home. That's not something I ever thought of. But there's a limit. You can only have this many people. And did that person want to end things? No. But she didn't have any other option for housing. So the disparities can be working women that have access, even with access, there can be disparities. I forgot, I am so tired. We started this with, what do people need to know? Yeah? Hope. Change. Something. I don't know.
So I am a mom of a 2-year-old, but I'm also 24 weeks pregnant. So this came out about the time I found out that I was pregnant. It was very emotional to hear that about Roe v. Wade. I know that's probably, I'm not supposed to say that, but I know that's the elephant in the room at this time. So just know that it's okay to not understand, and it's okay to have an opinion, or have an opinion that's not the same as everybody else. So just know that maybe where you live, or maybe where you are at, is not the same. You may think differently about how this was overturned, or how this was it. And just know it's okay to not be the same as everybody else. And it's very okay to have different opinions. That doesn't mean you're wrong. So as things go through, and as you guys go in like about everything, and in general aspect, but definitely this, it's okay to be different in this space.
It's a very good point. And that gets back to reproductive freedom. It's not my obligation or my job to make choices for other people. It's my job to lay all the options out there, and then you make the choice you make. And when you make that clear to your patient, speaking as a nurse, the relief that comes on people's face. You mean you're not going to make me take birth control? I'm not your mother. Do what you want. You don't want to have birth control because you want to wait until you're married? Good for you. That's a fabulous choice for some people. And it's not a choice for everybody. And I spend sometimes talking to people, I'm going to be abstinent, we're going to wait, and encouraging that, what a healthy choice that is. And then life happens. And it's not always against somebody's will, but it can be against somebody's will. A lot of times 3 beers happen, and boy, things change after that. And so we talk about abstinence, that's the way, and it's very, very good. It's not 100% effective. Because you're abstinent today, what's your choice going to be tomorrow? And it's your choice and it's your decision. But if you haven't planned ahead for what if my decision changes, there can be consequences. We talk about that a lot. You got a thought?
So I guess I would say 2 things. One, you are the majority. I think you need to remember that the people making these rules are usually over the age of 65. They are often out of touch with current morality, and they have a set of beliefs that doesn't necessarily conform to the way most college students think. And so, as dark as things may look at certain times, as a historian, I tend to be optimistic about the future. And I think we'll come to some reasonable decisions. That's the first thing. But the second thing is, I wish I knew your name.
Me?
Yeah.
There.
Theron? We need more Therons in this room.
Absolutely.
That is, this is not, I would argue, just one side of the equation. We need all elements of society participating in this conversation. And even if it's just having a friend come and listen, they don't, as you said, you don't have to agree, but to understand some of the issues that students are confronting is a step in the right direction. And so those are the 2 things I would take away, that you are the future, you are the majority going forward. But we need other people, not just like-minded people, sitting in these chairs, hearing the conversation, making decisions.
Thank you. I think we need to continue to have these conversations, right? This shouldn't be the only time we discuss reproductive health and justice. I think this needs to be a continued conversation that takes on a holistic look at topics and really continues to provide this, right? This education, the resources, the conversation, and continue to provide that to our student body based on their needs and what they want out of these conversations. For example, we can talk about trans health and reproductive justice, on immigration, language barriers, and reproductive justice. Perhaps a panel where we connect with local community organizations that are doing the reproductive justice work on the ground level, and learn ways that we can contribute to that work, right? And more than anything, I just want you all to know that your choice, your voice, and your body matters. And I'm going to do everything in my power to protect and fight for that. So please do not think you need to do this alone. Social change happens through collective action, through collective resistance, through support and solidarity. So this is in part absolutely about our bodies. It is also equally about what our society deems permissible to control about folk with reproductive capacity. Sorry, this really makes me upset. We will not be shamed for experiences of sexual behavior and pleasure. We will not be shamed for making decisions that are best for our bodies. And we will demand to be viewed holistically, beyond our capacity to reproduce. We will not be silenced. Thank you.
Wonderful, thank you guys. Because we didn't address this sooner on, I apologize. Probably should have been a question that we hit first. But what are some resources available to students that want to get help, really just anybody? And how should they go about seeking them? Who would like to start?
Would you say the question again?
Yes, of course. What resources are available to students that want to get help, and how should they go about seeking them?
Planned Parenthood. Planned Parenthood is still putting forward great efforts in supporting the community in terms of connecting folk to outside resources, financial support, education, and more. But also GEN, so that's the Justice Through Empowerment Network. I think that's also a wonderful resource that helps people in South Dakota in particular with funding for things like abortion and the costs associated with transportation, childcare, lodging, interpreters, medications, food, birth control, so on and so forth. And then if you're looking for something that's just online, I think Our Bodies, Ourselves is a wonderful resource that's relaunched recently. That is a feminist intersectional resource about health and sexuality. What's that? Yep, and they've had to bring it back in light of current events. But in terms of audio resources in particular, many of us on campus are what I would like to call us reproductive justice allies. I have a sign up on my office bulletin board that lets students know that I'm open to conversation and I actually have physical resources. So in my office, I always have condoms, dental dams, lubes, Plan B, and of course candy. But I also have power, right? I have power and support. So I'm happy to direct students to resources within or outside our campus, answer any questions, be a part of that process going forward if someone just needs some support and friendly face. And I think many of our professors and staff on campus do sincerely feel similarly. So I do recognize, though, that for many students, knowing someone you can go to for such things can be really foggy and not necessarily clear. Which is, again, I think why we need to be loud in our allyship.
Yes.
I think Spencer said something really important. Most faculty, I think, would be honored to help. They may not know how, but they would find the answers. The fact that you trusted them to share something as intimate as you shared is an honor. And I understand if students are afraid of that. You know, I don't know this person very well. Most faculty will keep their mouth shut. And that's the barrier that I think when you talk about an ongoing conversation, that you do have allies that maybe don't know.
So, all those things are amazing, and I'm particularly interested in the candy. What I have is the power of federal funding and Sanford health dollars. Nexplanon, the implant in your arm, is $3,000, not including your health visit. Most people at my clinic donate. When I make a donation, we accept donations. An IUD, if you made $100,000 a year and came to my clinic, an IUD is $363. That's 7 years of birth control. For most college students, some of you make pretty good money, and we're going to use a sliding fee scale based on your income. Most patients don't pay anything for that. Plan A, it's confidential. We love to bill insurances. We don't have to. You can say, no, I don't want you to use my insurance. Okay. If I tell, you talk about most professors, if I tell, I get fired. And I like my job, so there won't be any telling. I think a lot of people are afraid to seek care because they're afraid of what we're going to do. For many women with vaginas and uteruses, they're worried and upset about the idea of a pelvic exam. None of that until you're 21, or unless based on need. If there's a problem, I'll address it. But I have some of the best providers I've ever met with gentle and respectful. You don't want that done, we won't do it. We get it. And I think when you go to a clinic that is experienced with working with young people, I mean, I know waiters and waitresses at every restaurant in town because they don't have insurance. And we serve that population. We serve underserved people. We have 149 languages available for interpretation. We can speak in your language.
Tell later.
Oh,
Give them the
yeah,
address.
our address. If you go 6 blocks up Grange, there's a big hospital there called Sanford. We're in Medical Building 3. I have, Medical Building 2, what am I saying? I have brochures. How would somebody do that? Well, they would call our phone number and say, I'd like to come in for birth control. And the registrar, who's the sweetest lady on the planet, will take it from there. It's very, very easy. And you know, if some clinics you'll wait 6 months, we'll get you in the next week, maybe 2, depends on how busy we are. But we have plenty of room. And you have 3,000 condoms? I probably have 5. I just got a shipment. So we order them by the gross.
You have 3,000 condoms.
Somebody at the school does. And
Okay.
we have latex free.
My office isn't that big.
They don't take up a lot of room. We have latex free and variable sizes, which are also important. We talk about condoms. People spend 2 days figuring out which brand of shoes they're going to buy and 18 seconds choosing a condom. Choose a condom you like. It's very important.
And so,
That's fine.
will you just say the name?
Our clinic is called Sanford Midtown Clinic. We used to be down in the 8th and Railroad, and we were downtown, and I wanted to name it Downstairs Healthcare, or Down There Healthcare. I said, oh, I have a problem, and it's down there. But they said, no, we can't. So, Midtown Clinic.
The biggest resource I would say that I could give on campus is to know who to go to when students have questions. I will never say I'm an expert in this area, and there are people on this campus that know much more than me in this situation. So I just want to be the person that, in my world, would be student athletes can come to and be like, I need help with this, and I can get them the resources that they need. I'm not going to be the person that has all the answers, but I can get them where they need to. I'm sending them to your office, really.
That's happening.
We don't stigmatize sexual pleasure behavior here.
All right, so when we talk about treatment options, which you did so beautifully, when should students know when to seek self-help versus going to a clinic when it comes to their reproductive health?
How graphic do you want to get? Thick, white, chunky, itchy discharge, go to Walmart and get a Monistat 7-day course, treat your yeast infection. Vaginal discharge almost always will get better following a woman's period. Any time a penis has discharge coming from it, it needs to be tested, and that means a visit to a clinic. People are terrified that we're going to swab something. Pee in a cup. Very, very easy to do. People ask me, what are warning signs? And the warning signs I know for people with a penis and testicles: discharge from the penis, pain in the testicles, pain with urination. Penises don't get UTIs the way women do. If women have pain and burning with urination, you need to get in. That's possibly a UTI, but also a really fun side effect of chlamydia and gonorrhea. If you're concerned about an STD, you need to be seen. You cannot, to my knowledge, you probably know online where you can get STDs. I don't know, but our results come back in a day and a half. It's not like it's a long time, and we have free medication to treat. Things that are concerning for people with the cervix: bleeding with intercourse, pain with intercourse, a general feeling of pelvis pain, green frothy discharge that smells like something died. That's infection that needs to be looked at. You cannot treat that over the counter. Most women have a normal cycle, and women will come to me and say, it just doesn't feel right. You're right, that's not right. But on the other hand, people will say, well, I always get my menstrual cycle every 29 days, and now it's 34 days. Well, we're not computers, things will change. But when you really like, this isn't right, you need to be seen, and it won't be scary.
I think that was a softball question for you. Really? Because yeah, exactly. I'm not a healthcare professional, and I think you answered that wonderfully.
I've been talking about this for a while.
All right, our final question now before we get to the Q&A, where we will offer up students the chance to pose some questions to you all. The contraceptive resources available around campus should hopefully be a starting point for Augustana to advocate for their students' right to choose. How do we as students continue to advocate for reproductive health in South Dakota and the Augustana community and ensure that students' concerns are heard? So kind of specifically, if you can keep this answer to how should this question apply to young people?
I already know what everyone's going to say in regards to at least one piece. Vote. If you're here at Augustana University, that means that you're actually allowed to register to vote. So you're right, things like this panel talk or getting emergency contraceptive access on campus are wonderful first steps to ensure that there is this transparency and the conversations are in fact happening, right? Again, I think something I've already mentioned before, I'm going to mention it again, we need to continue having these conversations. That this shouldn't be the one and only panel where we're having discussions around reproductive justice. And again, the intersections of varied experiences and how that might result in different forms of information that we need to get out there to the community. Have different stakeholders, different experts up here on the stage and ensure that everyone's needs and experiences are being met when it comes to reproductive justice, because that can just be so variable and different depending on people's needs and social identities.
Got me covered.
I'll add one thing. I think it's really important that you understand what the ELCA said about abortion. Because I think you can make a series of arguments about why these things need to be available and how they fit the mission that the ELCA has laid out. It's 12 pages. It's readily available. And it does say that abortion, in this case, while the last choice in the ELCA is a viable option and lays out certain conditions and why you shouldn't have to make a choice. In fact, they condemn not having a choice in the ELCA. So one of the things I think you need to do going forward is if you're going to talk to the constituents, because remember, we're owned by the Senate, you need to be able to talk their language and to be able to use their own document to defend what you think needs to be done is crucial. Because it places you on the footing that they have used themselves. And I would encourage you just to look at it. You don't have to agree with it, but be aware of what the church has said, the ELCA has said, so that you can counteract some of the arguments that people who haven't read the document are going to make. Good luck, sir.
The only thing I would add is bravo to ASA and the subcommittee, because you've taken that first step on what we need to do as a campus. But just not stopping here. And I think that's been reiterated. We're getting there and we're doing a great job. And I think this is a great first step. And then what's next? So that's my challenge to you guys.
Thank you guys so much. Right now, like I said earlier, we're going to open it up to students to ask. So if you guys would be able to hit the projector, it'll be really bright up here. I apologize for that.
Do you have the remote?
So for students out here, we're going to have on a presentation, on a slide, a QR code that you all can scan. That'll take you to a Poll Ev or Poll Everywhere link. And within that link, you can ask your question there. If you feel comfortable and would like to pose your question out in front, like speaking, pose it vocally, you are welcome to do that as well. We can hand the microphone off. But hopefully this Poll Ev will provide just a way for those who are a little bit more hesitant to ask the questions, as it is a stigmatized topic. So Erin's working on that.
Do we have any nursing pictures here? Staff.
It's a surprise. They've got a number.
and the more I work, the more I understood it. I think we said over and over, begin with people where they are, and the situation as it is. You cannot, this is the situation in front of me. What can I do to make things better? And so we have a situation in our state and in our country, and this is where we are. What can we do? And when you start from that point, you can complain and moan and groan about what has happened. We're not going to change it. Just say this is the situation. What steps can we take?
Thank you. So we have our first question. This one we touched on a little bit earlier, but I think it is such an important question about allyship. So how do we pull men into the conversation of reproductive rights, or really just anybody without a uterus, without vagina? Would like to take that one first. I can step out and hand the mic off too.
Well, I'm guessing that's me.
It can be if you want it first. Okay.
This is allyship.
I'm trying to think of a creative play with women with both sex.
This is Rada.
I'm sorry?
This is Rada.
This is Rod, right? This is, you're responsible in part, right? If we're gonna have something, we need to prepare. That is, it's not, pardon the phrase, hit and run. So that's the first part. And the other is, this is not a gender-specific issue, I think. And that's what I think it's pleasure for you to kind of get it. There are all kinds of people engaged in this. And so we have to think beyond just the binary. And so I think you bring friends. Partners, that's a better way to put it. And that's the beginning. You know, all of you have a father somewhere, even if you don't know that, right? They're half the story here, and that's important. I remember what got me involved in some of this is my daughter was a Fulbright scholar. And I knew that more than 50% of the women had been raped in the country she was going to that year. And I had to have a conversation with her about what happens if you get attacked. What happens if you were raped? She's half the world away. That is unfair. The men that were going on this full ride, they weren't worried about that. That's an unfair burden. And I think it's just reminding people of that unfairness, this disparity between who bears the burden in some of these issues is the way of getting started.
Thank you. Okay, I'm just gonna pose these questions in the order that they've been coming into the Pull Everywhere app. So why is birth control only for women or people with uteruses, or uteri? I don't know the plural. Actually, so who would like to?
Systemic sexism. Taking my medical sociology course. So I do want to note that there are currently things in the works, but tongue-in-cheek comment worth noting, all the side effects and symptoms that folk are experiencing when we're talking about male birth control are akin to what folk with a uterus do experience currently with most forms of birth control, and those are the side effects that are holding them off from putting it on the market. And so it makes us critically examine whose pain is valid, who holds the power and positions of power in pharmaceutical companies, insurance companies, and so forth, that create these structural barriers of access to particular types of things like birth control. Yeah.
I agree with that. And medically, I would say we have found ways, and again, who runs the research? But we have found ways to stop one egg versus a billion sperm. And it's really not horribly difficult to block that egg. Years ago, I heard about a study being done where they were going to inject a gelatinous goop into the vas deferens to block sperm. And when that person with, I work primarily with cis women, so I tend to talk about men and women in that frame, and I apologize. It's not that I'm not aware, it's daily. And then when that person was ready to have children, another injection into the vas deferens to dissolve that goo, and they'd be ready to rock and roll. And the problem, they couldn't get human studies because nobody wants a needle into their testicle. And yet we shove a wishbone into a woman's uterus, and that's not a party. So there are physical reasons, it's just easier. But there's some research reasons as well that I don't have control over.
I would just say individuals with a uterus are tougher. That's why.
Well, that's true.
That's what I have to say.
Yeah, it's.
Okay, for our next question, this person states, I'm not a nursing student and I'll probably never receive a formal education on health. My question is, where do I go to learn more about my body and everything that's happening down there? Do you want to take this one or you just...
Come see me. There's great resources. There's great resources online. Choose your website as well. I would never encourage somebody to read somebody's blog. And you can find them. All the women who hate their IUDs. There's thousands, but there's 1 million who love it. So you have to be looking at your choices of where you learn. Find a healthcare provider you trust and ask the questions. Write the questions down before you come, because and I keep a list in my phone, because when you're face to face with someone you don't know well, those questions go out the door. And so keep track of your questions. There aren't dumb questions, and we're here to answer those questions. And I'm amazed at some of the things people ask me that I never even thought of that. Let's think about that. It's always amazing. No? Spencer.
And here's the thing about that question. We don't have any form of standardized, inclusive sex education available to youth, and that's a problem. I believe only around 18 out of 50 states require medically accurate sex education in their public school systems. When we're talking about being queer inclusive of the queer community, in regards to sex education and not being heteronormative and understanding the lens of what sex entails, there are 3 states that actually require the school system for you to talk about it in a stigmatizing way. The abstinence only being pressured in a few states. There's some states that require you to touch on the importance of waiting until marriage. And so you see how we can get into then a college, an undergrad experience, and feel left wanting about our bodies and knowing how they work, not even just with our interactions with partners and other people, but our interactions with ourselves and understanding what's going on with ourselves. And so again, getting, surprise, surprise, the sociologist wants to bring it back from the individual and how it's connected to the structural problems that are happening. We need to have some form of reforming of our policy structure, our policies and standards of what is considered to be, care and sex education standards in our post-school systems. But for right now, in this moment, I would also say though that the Our Body Ourselves is quite sincerely a wonderful resource. But if you also want to look at some more large data of what's going on in regards to like STIs, STDs, pregnancy, sex education, and all those standards, the Guttmacher Institute is also a wonderful resource as well to kind of connect your experiences to what's going on, not just nationwide, but also worldwide as well.
Thank you for that resource. I did not know about that. We have two final questions. So the next one is, how can you let college students know that we can reach out to people like you all? Meaning just somebody with any expertise regarding reproductive health. And what can people like you do to break that barrier?
I love that because the accountability and the ownership of doing that work is placed on us, and I think it should be in a lot of ways. And I think kind of swinging back to what I said before, I literally have a sign on my corkboard in front of my office that says Reproductive Justice Ally for discussion and actual physical resources. It is like my version of like a different, I have my safe space, but I also have my reproductive justice safe space, and I am loud with that because I need to signal that I am a safe space for those conversations and resources. And I do think, again, we need to be loud in that allyship because we don't want students who are already having to navigate a very stigmatized conversation, experience, and topic. They need to know quite transparently who they can feel safe interacting with and having that conversation with.
I don't know that for change.
I think it's a place of growth for our campus. One is to find people like yourself who have the safe space and growing that. Is it a sticker on your corkboard?
I made it up.
Right, so stuff like that. You know how you have like DE&I has things, or LGBTQ has things that you can put on your door, and this is a safe space. I think that's a great way for our faculty and staff to add another spot that they're a safe space that you need to do that. As for any of us, our names are somewhere that if you really wanted to get a hold of us, just find our names on and send us an email. I'm sure any of us would be willing to talk to you if you needed it.
Oh, okay. Our final question is, why is it never talked about that men have the ability to prevent pregnancy with a simple procedure as well? Why is that burden only on women, both to prevent pregnancy and terminate it as well?
I turn it two different ways.
Whoops.
When the question about why are there no male birth control, the first thing I thought of was a vasectomy. I mean, that was the first thing that came to my mind. And men are afraid to have it snipped. So that, it's not talked about often enough, I think, that there. The ELCA document specifically states that men are just as responsible as women for pregnancy. But then the next line, and it's important, but pregnancy falls disproportionately hard on women. That's the key. The disproportionately hard, because you carry the child. You carry that around. And that's the crux, I think. How do we make men more responsible? I don't have a good answer. I wish I did. But I think part of it is men have to make decisions. I would argue some of them are moral decisions about this. But the unfortunate or fortunate, we'll say it's fortunate, right, is that men don't deliver. They don't carry.
And can walk away.
And that's the problem.
So you can walk away. A woman, you can't walk away. And nothing you want to.
I didn't mean to interrupt.
No, I'm sorry.
No, because this came up when my daughter was in high school. Why does my daughter, we couldn't, now she didn't become pregnant, so don't walk out, oh, well, it's daughter became pregnant in high school. That's not what I'm saying at all. But if she had become pregnant, we could not get child, there's no guarantee that we could get child support or make that young man responsible. He's under 18, there are all types of laws. It was going back to Spencier's structural problems. So those are some of the issues. Spencer's got 1,000 more I can tell.
I think we need to consider how we understand sexual behavior and pleasure overall. I think again, structural sexism, who is owed sexual interaction and behavior and pleasure and who are framed in a way that they have to be defending the morality of their body from people who are both sex. And so again, I think even the conversations we're having from the get-go with young children influences the framework of who feels like they need to be in constant vigilance around their body and the way they have to, think night and day about how it interacts with other people, and vice versa, not so much. Again, so how do we socialize these very gendered behaviors onto people, right? Because this isn't biological, it's very social. That we socialize when we're thinking in binary terms of women and men into these very stereotypical standards of what it means to be a woman or a man. If we talk about consent from kindergarten, then it's not going to feel like this strange phenomenon when we get into forms of sex education in 8th grade, right? Where everyone is starting to learn about what emotional intelligence looks like, to be able to have access to the full range of emotions. Having those type of conversations from the get-go means that by the time we're seeing folk interact with one another sexually, that perhaps we're seeing different perspectives as to who bears responsibility in having a consensual, healthy interaction with someone else.
Can I please spend another 2 hours on consent?
Okay. I'm sorry, I don't want to go. So anyone who takes my Western Civ class knows that I say this. Americans do not know how to drink. And this goes back to how they're taught. You're taught to binge drink. And this goes back, I mean, in fact, we don't have these conversations like they do in Europe, where you learn to socially drink. That is, you gradually, and then they have laws, very strict laws, that you're not going to do it. It's not, my point is, it's not just when it comes to our bodies, not just when it comes to consent, that these issues emerge. You can look at a number of other issues that cause problems elsewhere. It's the same thing. We don't have these conversations early enough. We don't teach early enough what the responsibility is, how to do certain things. And so when you talk about that, it's not just when it comes to sex in our bodies, it's what we put into our bodies that I think we fall down in our educational system as well.
And I think it starts before kindergarten. I have 2 grandbabies. Yeah, 2 grandbabies. Well, he's not a baby anymore, but the little one, we spent a week together this summer, and I was not her favorite person this year, and I was a little sad about that. And her mommy said, "You give Grandma a hug." And she said, "No." She goes, "Come on." No. She said no. And if we can teach a girl at 2 that when she says no, her body will be respected, or for that matter, my grandson, your body will be respected. If you want to hug me, you can. That's where it starts, right away. Now, I read somewhere that someone was asking their newborn permission to change their diaper, and I thought that was a little far. But the concept.
Okay, we have one final question. Ashley, a student, would like to come up and ask. I'll just,
Hi guys. So my question has to do with, as we're talking about reproductive health, we also have to talk about like sexual assault, right? Because that is something that not only affects us emotionally, psychologically, it also affects us physiologically. And I think like one of the biggest concerns I've heard is that although we want to come to faculty, it's difficult with the mandatory reporting. And so how do we navigate that as students? Because that is like a huge hindrance to people asking for help.
So I think knowing who's not a mandatory reporter on campus is a very big start. And we actually have more than one person you can go to, which is not normal. And I think that is a great start to the system. Also, I've only been here a month, so names, not starting off, you got the names. So that is one thing to know, because we are, because of the law, have to report everything, so.
Absolutely. Mariah is our mental health and wellness specialist who is not a mandatory reporter for that exact reason. And so I have cue cards always just on my desk. Because absolutely, I've had students come in and be like, listen, I want to have a discussion with you, and I'm a little nervous about that because you're a mandatory reporter. And I'm like, listen, Mariah. Mariah is the person and has a background and a degree be literally on making sure that we take care of you holistically in both your experiences, your physiology, your mental health, your physical health, and all that encompasses. And she's a wonderful human being, so. And that's such a good question, so thank you.
With that, I think that's the end of our panel. So I just want to thank you all for being here again, sharing your expertise and time with us. As far as closing thoughts go, closing remarks, I just want to bring light again to ASA's Reproductive Health Initiative. So those dispensers that I spoke about earlier, both condom and Plan B dispensers, will be made available within the next week. So you can look for those on campus. And if you have any questions that ASA can answer, we are available on Instagram as well as email. Our office is located across from the dining hall, as well as all of these wonderful humans up here and really anybody else on campus. The goal of this panel is just to destigmatize reproductive health and all the issues that come along with it on campus. So thank you all for being here today. All right, let's give a round of applause for them.